Assalamu alaikum, hello everyone, this is Ahmad.Madkour. Here in these videos we will try to show some unedited full procedures for some third space endoscopy technique, hoping it can offer a real life experience, show all the difficulties, challenges and strategies which can help some friends who are interested in such procedures. The first case here will be a case of POEM, standard POEM for patient with type 2 achalasia. We start our procedures for the standard type 2 achalasia, 10 centimeter above the cardia. We do submucosal injection. We use just saline and methylene blue. We never use adrenaline while doing POEM. After we do the injection, we go for the mucosal incision. One tip, it's important to say in the mucosal incision to have a nice cushion. You just push your wheel down so you can see the mucosa in front of you using your cap, and then you start to do the injection not so far from the injection site. Usually this oozing or bleeding which may happen, it's a capillary and usually it's a stop. Here we will use a flash knife from Fuji. We will do the mucosal incision. We use a push technique. After we do the initial incision, we push our scope in and little up so we can have a nice incision. We use Endocut I222 for the incision. Then we start to make this opening more wide. Here we use spray coag, effect 240 watt. We should be very careful while doing this not to have a muscle injury during the initial incision. Also, we shouldn't be shy. We should do a nice cutting of the muscularis mucosa until we can see the muscle layer here down, so we can go easily to the submucosal space. Here we reverse the view. You can see we have our incision up, although we are working from the posterior wall. And then we move now to the submucosal space. After we do repeated injection, we start to cut the submucosa. You can see here we still use the spray coag current. It's very important to have a wide tunnel from the start, not just to cut and push. It should be wide to the right and to the left, so it's be wide enough. If it's very wide, you will have a mucosa falling up to you, and if it's narrow, you will have a problem while moving near the cardia. And it's very important to check your direction. Now, after we did some dissection from edges to center, from right and left toward the center, and this is the best way, I think, to have a wide tunnel. We go back and we check the direction. When we go back, we see that we are perpendicular to the circular muscle, so this is a nice direction, and we continue again in this position, and we repeatedly inject through the knife again the saline and methylene blue, and go on our way toward the cardia. Not all cases are similar. In this case, it's a naive patient with short time of the disease. It's a not long-standing disease, so we didn't see a lot of fibrosis. We didn't see a lot of new vascularization, and such cases is very nice to start with for the beginners. But sometimes the submucosa is very vascular and we have a lot of vessels and fibrous tissue, and we couldn't go that fast. But not all cases are similar. You can see here we still continue to dissect from the edge to the center, right and left to the center. To do this movement in an easy way, we keep pulling back and pushing in our scope. So we pull it back and move from right to center. While we're pushing inside, we pull back again from left to center while we're pushing in again. You can see here sometimes we touch the muscle and we have a superficial like muscle burn. This is okay while doing poem because we want to keep the mucosa intact and avoid mucosal injury. Here we use a gastroscope from Fuji, which is 760R. The outer diameter is 9.2 and the working channel is 2.8. And you can see the accessory channel is going out almost at 6 o'clock, which is very nice to be neutral, and it gives you a nice control for your dissection. Usually we use coagulation current while dissection, but at some points where no vessels and we need to have a fast cut, we can use endocut. Still, it's endocut I222, which is the yellow bevel, and we use the blue bevel in most of cases during the dissection. And it's usually very important to be oriented what is where is the muscle, where is the mucosa. And usually we say we should see two structures. It's not only to see the submucosa, you should see the submucosa and the muscle in your view, or the submucosa and the mucosa, so you are sure where exactly in the submucosa you are cutting. Here we start to be close to the cardia, so we do a repeated injection and start to make it little bit wide on the side. We didn't just cut on the center. If we just keep cutting on the center, the view will be like a cone. So in the end, it will be difficult. And if we have some bleeding, it will be more challenging to control and we'll have more gas-related complication. So it's very important to have a wide tunnel. You can see here, I think we are very close to the cardia, and we cut very close to the muscle, but we should be careful not to go intramuscular, because sometimes because we are very cautious and we care about the mucosa, we go very close to the muscle, so we cut the muscle and go intramuscular, and this is also cause a problem. Now we do injection again and we can see the nice blue color, so we can cut. And as you can see, we didn't just move to the center, we dilate from the side to the center and from the side to the center, and we start to move now to the gastric side. How we know? It starts to be a little bit wider, but we will see more clear now. Again, we inject to the side, although we can go to the center, but it's very important to dilate the side to the center, not only from one side, not from the side, right or left, but from both sides, right to the center and the left to the center. And again, we dilate now. And you can see it's became white. Usually we can look for spindle veins and ballicedial vessels, but it's not always. Not always it can be seen very clearly, but we depend on the feeling you pass from tight to narrow, and you start to see the direction of the muscle is different. You start to see oblique muscle of the stomach, and you see it's become very wide. And you sometimes you see the perforators, but again it's not always that clear and not always there. I think it's very important to go enough in the gastric side. Maybe we didn't do extensive myotomy, but at least we move enough. All this part was in the gastric side, and little bit back it will be the cardia. There is some oozing here from small vessel, and we just spray, but we didn't try to touch the mucosa. If it didn't stop, we should shift to coag and now you can see this is the narrow part and with the stomach, and this is our tunnel. And now we start to aspirate some fluid and the gases and go toward the stomach. Now you can see the cardia is much more lax, although we didn't do the myotomy. Sometimes we do retroflexion to check for the blue sign, but it's not an accurate sign because usually fluid move down. So even if you didn't go in the gastric side, you may see the blue color. We think now we move enough in the gastric side. We go out and we'll try to clean the lens of the scope to have a better view. Then we go back to check and start doing the myotomy. Again, this is the tunnel, and no more oozing is there. And we go back totally, and when we go inside, we try to be below the incision by 1 to 2 centimeters below the incision. Then we start the myotomy. What's standard here to do a selective myotomy followed by full thickness myotomy above the cardia, but it's still accepted to do a full thickness myotomy from the start. It didn't have effect on increasing reflux as was thought before, and it actually makes the procedure more fast. And here we go for full thickness myotomy from the start. When doing this, we should be usually cautious, and we use the push technique. We hook the muscle fiber and push our scope in and up so we can cut the muscle. Usually we use a coagulation current in the first cut. Sometimes we use endocut in the second cut, or continue all the cut with the coagulation current, but at least the first cut should be with a coagulation to avoid bleeding from the vessels which may pass through the muscle. One tip here is to keep always your direction in mind, not to move to the side of the tunnel with your myotomy, because that may cause a problem. So usually try to be in the center and try to keep the direction of the cardia in view while we're doing this. Here we continue. Sometimes we use endocut, as you can see. At this point, we stop to look what is here and to make sure of our plan. So you can see down here, this is not the muscle, it's like a retroesophageal structure. So we adjust our plan, and again we look to make sure here is a muscle, and we didn't need to cut deep in the backward. So it's always very important when doing the myotomy to use coagulation to make sure of your plan not to go so deep. It's very important to keep the adventitia intact. It's an easy but dangerous. The myotomy, it's an easy step, but it's dangerous, and you should do very carefully while you proceed. And also it's very important because it's the final aim for our procedure to have an enough myotomy. Now we continue to do the myotomy. We're moving to the gastric side now. We should be very well oriented with anatomical structure here, as you will see. Now you can see the muscle become more thin. We can see some oozing of blood. We didn't think it's a marked oozing or it's a spurter. So we continue to the myotomy to cut the muscle, and then we will check this after we finish. You remember there was some oozing from the mucosa on the left side during the tunneling procedures, and it have some oozing now, and we will try to control. Now we finish the myotomy. And now we check, we can see here the peritoneal fat, and this is the most sure sign. We go enough in the gastric side. You can see here this is a diaphragm. So this is a diaphragm, and we move in the gastric side for about 2 centimeters, and this is the esophageal adventitia. It's totally different if you can look here from this view. This is a peritoneum and peritoneal fat, while back is the esophageal adventitia, and in between is the diaphragm. And this part of muscle is still there, but we didn't need to cut, not to increase reflux symptoms. And now we exchange our instrument to have the coag try to coagulate this mild oozing here, not to have a delay bleeding inside the tunnel. When we use a coag we use a soft coagulation current. Here we use RB Vio 300D. We use soft coag effect for 80 watt. If we use a Vio 3, usually we use soft coag 6.5. It was just a mild oozing. We didn't need to grasp. We just touch with the monopolar coag grasper, so it can just burn from the outside. And now we go back, and here is the full thickness myotomy. We go from the beginning with full thickness myotomy. After this, we check the mucosa to make sure we didn't have any mucosal injury after the myotomy. And we go to the stomach and try to aspirate any fluid or gases to relax the abdomen and decrease any pressure. After that, we go back for closure. One is of the most easy steps, but most important, because after all this, we just see the adventitia, peritoneum, and diaphragm. If we didn't close in the right way, it will cause a leak and mediastinal infection, which may be a big problem and sometimes fatal. While we're doing the clipping to close the mucosal incision, the first clip is the most important, and usually we close from distal to proximal. So usually the first clips added to a normal mucosa, so just on the tip of the incision. So after we fire the first clip, you can see a nice tinting of the incision, as you can see, so it's more easy to place the other clips. I'm sorry the quality of recording is not the best, but I hope in the next videos it will be better. This clip is from Microtech, and it's a rotatable click and a nice clip to use to close this defect. Again, we rotate the clip by the assistant of our assistants to have on the right location before we open. Then we close. Usually we didn't need to be very tight. It shouldn't be very close to the other clip. Sometimes it causes more problem if it's very close and it cause some ischemia. So usually this is the distance, and even sometimes longer than this. And now we place the third clip. And it's very important to check both sides, on the right and the left, to make sure that there is a nice closure and no gaps is over there. And this was a procedure, and hope it was helpful. Thank you.